has done a lot of work around HIV and housing, and so we're extremely excited to have her facilitate or present this topic to you. So I'll let Christine introduce herself, and then she'll go ahead and get started with the presentation. Thanks.
Good morning. I'm very excited to be here with the folks from Black AIDS Institute to talk about HIV/AIDS housing and its relation to ending the epidemic. I've been with the National AIDS Housing Coalition for about 12, 15 years in various capacities as a board member, as the chair of the board, and now currently as a consultant working for the National AIDS Housing Coalition, specifically around the area of housing as healthcare and housing as prevention. Throughout my career, I have run housing programs, developed housing programs, as well as done advocacy around housing, as well as technical assistance. Kind of a spectrum of experience around doing HIV/AIDS housing and housing in general for the larger community of people with disabilities. So again, I'm really excited to be here today. Next slide. Today, we're going to talk about housing and the HIV/AIDS epidemic as it relates to homelessness, prevention, and healthcare. We're going to talk a little bit about housing, our housing advocacy priorities, specifically as it relates to how modernization, the housing opportunities for persons with AIDS, and how we want to see that program change, as well as our appropriations at the congressional level. And we'll also talk a little bit, really address housing when you're doing your advocacy around the HIV/AIDS epidemic. Next slide. So, the National AIDS Housing Coalition envisions an international community where housing is a human right and HIV disease ends. We believe that in order to end the epidemic, you're going to need to end homelessness. You really need to look at how housing improves the health outcomes of persons living with HIV and how it reduces new infections. We see that it is an integral part to ending HIV/AIDS, and that if we really are focused on this, that addressing housing instability is a key to that piece. Over the years, the National AIDS Housing Coalition has hosted a series of 8 research studies. One of the reasons that we actually embarked on this was that we saw that there was not enough research gathered in one place to really talk about some of the things that we intuitively knew. So what we needed to do was really show housing's role in health, housing's role in prevention, and housing as a cost-effective intervention. Next slide. So through these research summits, we've been able to show that housing is a proven structural intervention in both treatment and prevention. We've worked very hard with the federal government to make sure that housing was included as part of the national HIV/AIDS strategy. And one of the things that we've heard is that housing is so expensive to do. So we've spent a lot of time and energy showing that housing is a cost-effective intervention. And so that as we move forward to looking at how we're going to end the epidemic, how do we really integrate stable housing as part of the solution in ending the HIV/AIDS epidemic? So as I move forward, we're going to really look at housing as it relates to homelessness, housing as it relates to prevention, and housing as it relates to healthcare. Next slide. So when we think about housing and HIV and homelessness, we know a couple of key factors. One, that the rates of HIV infection are 3 to 16 times higher among persons who are homeless or unstably housed. And we also know that at least half of Americans living with HIV experience housing instability after they are diagnosed with HIV. So what does this tell us? It tells us that we have to work and intervene at the level of shelters and homelessness all across the board if we're really going to get a handle on HIV prevention. That means testing early, testing in those structures, and also it shows us that we need to make sure that there is access to safe, affordable, decent housing to people after they are diagnosed with HIV. If we are able to address that basic need early on, we know that that portends for a more successful treatment regimen. Part of the reason that HIV really impacts the health of people living with HIV is not only that it's a good thing to have, but also that it actually reduces stress, which allows for medications to be more effective, and allows for safe, decent food, refrigeration of medications, which allows for people to really engage in their treatment. And it also allows for them not to be worried about one of their basic needs, so they actually engage in treatment earlier. Next slide. The other thing we know is that housing is HIV prevention. People who are homeless or unstably housed to receive housing assistance are more likely to engage in medical care, reduce their risk behaviors, and enjoy better health. When their housing situation improves, people living with HIV and AIDS reduce their drug-related and sexual risk behaviors. One of the things we've been really concerned about, and I think everyone listening has been concerned about, is viral suppression, really achieving viral suppression as a way to prevent the spread of HIV. When people are virally suppressed, they are much less likely to be able to spread HIV. One of the things we know is that making sure that people are housed allows them to get to viral suppression because of some of those things that I just talked about. More effective implementation of care regimens, earlier access to treatment and care, stable living environments, access to clean water, access to good food, all of those things that are necessary to improve someone's health. So we can see that when we think of housing in terms as a prevention intervention, we are actually broadening the ability for us to address the epidemic. Next slide. So the next thing I really want to talk a little bit about is how housing really is HIV healthcare. There's a doctor in San Francisco by the name of Dr. Josh Bamberger who has been really key in talking about housing as healthcare. He actually has said that he wishes he could give a medical prescription for a unit of supportive housing. One of the things that we know is that when people are homeless or unstably housed, that people are more likely to enter care late, have lower CD4 counts, have higher viral loads, they're more likely to be hospitalized and use emergency services, and experience higher rates of premature death. So what we know is that when we house people, we are increasing the likelihood of treatment success. We are increasing the likelihood of people having a higher quality of life. And that's what we really want to be able to focus on, is how that housing really has a direct correlation to improved health outcomes. Next slide. So we also know that the provision of safe housing to people living with HIV and AIDS at risk of homelessness has been shown to more than double the odds that the individual will have an undetectable viral load. And this is done because they have access to health service. They're more likely to attend their primary care visits. They receive ongoing care that meets the clinical practice standards. Again, we really are focused on getting to viral suppression. That is kind of the barometer for which we measure success. If people are getting to the point of viral suppression, and we now know that stable housing is a key element that allows that to happen. In addition, we can look at things like lack of co-infection with things like Hep C, tuberculosis, other STDs as well. So again, we're looking at the overall health of the person and being able to improve their overall health outcomes. So one of the things that the National AIDS Housing Coalition has really embarked upon is called our, next slide, is called our Housing as Healthcare Project. The goal of the Housing as Healthcare Project is to get to a future state of integrated healthcare delivery that includes federal support for state-level innovation. What we mean by this at a very basic level is that, or a very ambitious level, is that if we really believe that housing is healthcare and that housing is a medical intervention, then we need to have a financial structure, a sustainable financial structure where housing is covered as part of the medical process. And in an ideal world, what we'd be looking at is a sustainable funding stream such as Medicaid that would significantly expand available housing supports toward a goal of meeting that end. So recently, as recently as last year, the Centers for Medicaid and Medicare Services put out a bulletin really encouraging providers to closely connect housing support services, let's connect support services with housing to make them an integrated delivery system. To be perfectly honest, we don't have support of groups like CMS to have Medicaid cover housing, but what we do have is that the understanding that housing is integral to improved health outcomes. So one of the things that the National AIDS Housing Coalition is promoting is that if that is the case, that the government and that the funders of medical services really see the benefit of housing as a medical intervention, then how do we get that covered in a way that's sustainable? Right now, most of the housing programs are grant funded, and what we often find in most communities is that the housing system is overtaxed. For instance, in Washington, D.C., our waiting list for low-income housing is about 19 years long. That is unacceptable for people living with HIV and other chronic conditions, because not only have we been able to show that housing is health care as part of the lives of people living with HIV and AIDS, we've also showed that housing is health care for most people with disabilities, be it cancer, diabetes, high blood pressure, hypertension, those things. Stable housing is a key ingredient to improving overall health outcomes. So we've been working with people who have vested interest in improving the lives of people with disabilities and really making this come to fruition. How can we look at the medical community really integrating housing into its service delivery? They understand it on a theoretical level, and now what we're trying to do is how do we make that come to life in a real practical level? Next slide. In the HIV/AIDS community, one of the things that we look at in terms of improved health outcomes or how we're doing in addressing the HIV epidemic is we look at the U.S. HIV Care Continuum. And the slide you have in front of you, I'm hoping most of you are familiar with, that really shows that we have a ways to go to get people who have been diagnosed with HIV to the point of being virally suppressed. As you see, in 2012, the continuum showed that only 39% of the 87% who have been diagnosed have received care, only 36 were prescribed to ART, and only 30% were virally suppressed. The goals and objectives in the National HIV/AIDS strategy move to directly address this so that all of those blue bars can be increased dramatically. One thing that we know is that if you overlay housing on the HIV care continuum, you see a drastic improvement. Next slide. In New York City, one of the things they did is they actually overlaid housing on top of their HIV care continuum. And so what you see in this slide is that of those diagnosed HIV positive, that 71% of them have become virally suppressed, as opposed to 50% of those who have been diagnosed who did not have housing. So you see in there that those who are receiving HOPWA benefits are actually more likely to be virally suppressed than those who are not. So one of the things you see the improvement in linked to care, retained in care, presumed to ever start therapy, as well as viral suppression. So this is a real clear depiction that when you overlay housing on top of the standard treatment without housing, you see a dramatic increase. We've been working with communities around the country for them to also show what are the benefits of HOPWA in their community. And we're seeing these kinds of dramatic increases, that when you are actually housing people as part of your continuum of care in your community, you're seeing higher levels of viral suppression. So again, when we're starting to think about the advocacy that we are doing around the country, one of the things we want to say is we must include housing as part of the overall spectrum of services that we are providing. Especially when you look at things like linked to care and retained in care. You see that there are dramatic increases in linkage to care and retention in care when we give people the opportunity to be housed. For those of you who may have some understanding of social work and Maslow's hierarchy of needs, housing is one of those basic needs that allows people to actually go above and beyond and start thinking about some of their more some of their other needs, like medical treatment, taking care of some of the other things that are important to them, being able to look for a job. When you are housed, you are more likely to be able to go out and think about employment. But until those basic needs are met, you aren't able to really think about some of those other things that are really important to the overall care and well-being of one's overall health. So a lot of this information feeds into the advocacy work that the National AIDS Housing Coalition does. One of the things that we really needed to show was have the data, the research that backed up some of the information and claims asks that we were making of our local and federal government representatives. In order to do that, we needed to be able to frame it in a way that really made sense to them. How housing is cost effective and the way we address it, how housing is a healthcare intervention, and how housing is prevention. And that if we actually address homelessness and decreasing homelessness, we actually are addressing the HIV/AIDS epidemic. So that kind of leads us into how we move forward and advocating for what we believe needs to happen at the federal level in terms of funding for housing currently, as well as funding for housing coming down the road. So the next few slides are really going to focus on what we're doing as advocates at the federal level and where we need support from the community to really be advocating in these directions. So the next slide is really talking about the fiscal year 2017 HOPWA recommendation. As you all know, right now we are in the middle of a challenging budget situation at the federal level, in that safety net programs have not necessarily been prioritized as much as we would like them to be. But one thing we have known is the Housing Opportunities for Persons with AIDS program, HOPWA, has been a successful program that has shown really strong outcomes for people living with HIV and AIDS, as you saw from the previous two slides. We've also seen that the HOPWA program has had bipartisan support from both Republicans and Democrats over the years. What our challenge continues to be is that as we become more successful in our ability to show these things, the funding does not match the need. So one of the things that we are doing is we're recommending this year that HOP will be funded at $375 million. Currently, it is funded at $350 million a year. And we really kind of break out how this funding would actually impact and improve things in the community. First, we would be looking for $12 million of that increase that we're looking for, which is about a $34 million increase, be distributed outside the formula. One of the things that I'm going to talk about in a minute is that we really need for the HOPL formula to be updated. HOPL was established in 1994, and the formula allocations have never been revised or updated over the years. So the way that money is being distributed is based on information that was available in 1994. As you can imagine, a lot has changed since then. So we're recommending that the HOPL formula, that HOPL be modernized is what we call it, and that part of the money that we're asking for, the increase, would allow for that modernization to happen without jurisdictions really being having to really lose money. So that 12 money would be distributed outside the formula to those HOPL formula jurisdictions that would lose funding with the modernization. And that'll become clear to you in just a minute what I mean by that. We're asking for $3.5 million to be dedicated to technical assistance. With the onset of the Affordable Care Act, one of the things we know is that for housing providers and HIV/AIDS service providers to be successful, they need to be able to have the infrastructure to be able to maximize the benefits of the Affordable Care Act. That means that they need to be able to either bill for Medicaid or other health insurance. And that requires a different way of thinking as well as a different financial infrastructure in their organization. One of the things that the National AIDS Housing Coalition is really key on is that the community-based organizations that are doing the work in the communities be able to continue this work in a way that really makes sense. So that means that they need the ability and the training to be able to build the infrastructures to be able to support these systems. As we move to a system where billing is key, that infrastructure, that financial infrastructure needs to be developed. And so the technical assistance would allow for those community-based organizations to get to the assistance they need to build that infrastructure to be able to maximize their connection with the Affordable Care Act programs. We're also recommending that $24.5 million would be used to expand the HOPL competitive program. What has happened over the years with the HOPL competitive program is that so many great programs came on board under the competitive process, but now are always renewed, which is understandable given the challenges to get sustainable funding for some of these programs. But what it has done, it has prevented any new programs from getting funded. So there's a lot of innovative ideas out there that currently we do not have the ability to fund. So we would like to be able to expand our ability to do some of these special projects of national significance that really are cutting-edge strategies to develop new ways to work with people living with HIV and AIDS in a housing setting. In many ways, we would envision those programs being that connection between housing and health care. How do we really integrate housing and healthcare in a way that makes sense and in a sustainable way? Next slide. So, as I mentioned earlier, we're really looking to modernize HOPWA. Right now, there are a couple bills before Congress that would deserve our attention. The one that's up on your screen right now is something that we're really excited about, called the Housing Opportunity Through Modernization Act. One of the reasons we are excited about this act is not only that it includes Title VII, which is the HOPL modernization as the National AIDS Housing Coalition recommended, but it's also combined with other modernizations in the housing field. So it's looking at some of the Housing Choice Voucher Program, as well as some other the broader HUD portfolio. One of the things that we have been really clear on is that you cannot just improve the HOPA program for people living with a HOPA program without really looking at the larger housing portfolio. What has happened in some years is that HOPA might have seen a modest increase in funding while other programs have seen a decrease. And what's really interesting is that people living with HIV and AIDS, housing providers, service providers use the whole spectrum of HUD programs to be able to provide services to people living with HIV and AIDS. So just simply increasing funding in one while decreasing some in the others does not benefit the whole. And part of what we're looking at is really strengthening the whole foundation. So the Housing Opportunity Through Modernization Act, also known as HOTMA, because you know we like our acronyms, which is H.R. 37, is a bipartisan amendment by Representative Price and Representative Adderholz. Notice those are both Southern representatives, which is really important. One of the reasons why that's so important is because we're seeing a large increase in the AIDS epidemic in the South. But anyways, this was a bipartisan amendment that was passed by the House unanimously and has been referred to the Senate Banking Committee. So one of the things we are asking some of our advocates around the country for is that they talk to their representatives, especially if they are on the Senate Banking Committee, to really support the HOTMA bill, H.R. 3700. Next slide. So what modernization would do, these are the specific elements that we are really looking to see happen, is that first and foremost, we would count the number of people living with HIV and AIDS. Currently, the HOPA formula looks at the cumulative AIDS cases, the AIDS rate. And what we're saying is that we would like the money allocated in such a way that it's addressing people living with HIV and AIDS. One of the reasons why this is so important is that especially as some jurisdictions have really gone up to speed with better data collection, we want to make sure that the money is going where it is needed most. But the other thing that we really want to stress is we do not want to destabilize communities that have had long-standing programs and are doing great work. And so as many of you know, is that when communities do allocations, they do it based on the available funding, and we do not want to destabilize those. So for instance, an area like San Francisco, who was really what was going on with their AIDS epidemic, has developed strong infrastructures that we do not want to see destabilized simply because if the formula were modernized, they might see a decrease in their funding. We'd also like to factor in differences in housing based on fair market rents and differences in poverty rates. We know, for instance, that it is much more expensive to develop housing in D.C. than say in Alabama. But we also know the poverty rates in Alabama are higher than they are here in D.C. So one of the things is we need to make sure we're factoring in the cost of doing housing and the poverty rates in the community when we're looking at the allocations. So for instance, a $400 subsidy in Alabama would go much farther than a $400 subsidy would go here in D.C. We'd like to continue eligibility for current grants subject to appropriations in the local comprehensive housing affordability strategy, with eligibility to be redetermined at least every 10 years. So we want to make sure that we're looking at eligibility and every 10 years. We believe that this length of time will allow communities to be stable and will get accurate reflection of what the changes or what fluctuations might be happening in a community. We want to phase in this implementation over 5 years to provide grantees time to adjust to the change. We are real clear as we've been going around the country doing this work that some areas, of course, are very excited because they might see an increase in their HOPWA funds, but we also see that communities are really nervous because they might see a decrease in their HOPWA funds. We also know that community change does not happen on a dime, so that if a change in funding happens, we know that there needs to be time for that system to adjust. We know that in some jurisdictions, for instance, when the allocation is released from the federal level, it can take as long as 8 to 10 months before that money actually hits the streets. We also know that the planning processes in communities can take several months, and we also know that some communities need to really understand what the impact of that change would be. So we believe that having 5 years for there to be some time to really adjust would make sense. We also wanted to include a stop-loss provision capping grantees at a 5% loss and a gain of 10% to the prior year's allocation. What this does, again, it allows us to phase in the change so that no one would take such a dramatic hit that it would destabilize their whole system. And it gives them time to do some proper planning over the course of the years for there to be some, to maintain that stability in the community. Our overall goal is we want no one to lose their housing because of this modernization, and we also want the money to be allocated in a way that makes sense and is equitable across the country. Next slide. So there's also a couple of freestanding pieces of legislation for the housing opportunities for the HOPWA Modernization Act of 2016. One is H.R. 4707, which was introduced on March 3rd, again, by Representatives Price and Aderhold. And the other is Senate Bill 668, introduced on March 2016 by Senators Collins, Reed, Kirk, and Schatz. It has been referred to the Senate Banking Committee. As you can see from a legislative perspective, we are trying to have as many ways possible to be able to move forward on HOPWA modernization. It has been in the National HIV/AIDS strategy since the first strategy that we really look at allocating money based on where the greatest need is. So it's been a consistent objective of the National AIDS Housing Coalition to really make sure that we're meeting the needs of people living with HIV and AIDS, and that the very limited resources are allocated in a way that makes sense and that is equitable. But again, this goes to a little bit why we actually embarked on the larger Housing as Healthcare project, because we know that we need to be able to build a sustainable funding resource for people with disabilities, especially people living with HIV and AIDS. If we truly believe that housing is a human right and people have a right to housing, then we need to be able to provide the housing based on that need as opposed to what's the available funding source of the time. Next slide. So that's the kind of the bulk of the presentation, and I would love to open the call for questions and answers, questions and discussions. And love to hear what you guys think of some of the things that we're proposing, as well as I'd be happy to answer any questions that you might have.
Awesome, thank you, Christine. I think if you have a question for Christine, you can either raise your hand on the panel to the right, and then I can unmute you and you can ask your question, or you can ask a question in the question tab on the panel as well. As we wait for questions to come in, I had a couple of questions for you, Christine. So, I mean, you talked about it a little bit about what advocates can do, and so most of the people on the call are people who work kind of in local communities, and so for folks who are, say, working in a community-based organization, how do you think that they can kind of help support or do advocacy for housing initiatives, either at the local level or at the federal level?
So at the local level, one of the things that we strongly recommend is that people are talking about and finding out how housing is being integrated into their community plans, be it at the red and white tables, be it at the community planning tables, be it at their healthcare tables, that people are actually looking at whether or not, one, they're collecting housing data, housing status of people living with HIV and AIDS. We know that many healthcare providers at the local level currently aren't even asking whether or not people are housed, so they aren't even able to address it at that basic level. The second thing is that if they are collecting that data, what they're doing with it, are they then either referring people to housing or helping people get into housing, or whether or not they're just kind of using it as a piece of information and not necessarily adjusting it. So at the local level, at the individual level, really finding out whether or not that data is being collected about housing status and whether or not they're actually using it. At the Ryan White planning, at the planning level, be it Ryan White, the Planning Council level, the Prevention Planning Council level, making sure that housing is part of the discussion as a structural intervention for both improved health outcomes as well as prevention of HIV. We are encouraging communities at the community level to really look at overlaying housing on top of their HIV care continuum and seeing if there is any if they see any difference when people are housed in their local outcomes. And if you bring up that topic and people would like to implement a HIV housing care continuum, please connect them with the National AIDS Housing Coalition. We'd be happy to provide them with a strategy. We actually have kind of a step-by-step strategy on how a community can implement a HIV housing care continuum in their community. At the federal level, what we need people to do is talk to their local representatives in Congress and at the Senate specifically about these two bills that we talked about. The Housing Opportunities through Modernization Act of 2016, which is H.R. 3700, and see if you can get your representative to support that piece of legislation, as well as the Senate Bill 2668, that is the Housing Opportunities for Persons with Modernization Act of 2016, that was introduced by Senators Collins, Reed, Kirk, and Schatz. So really making sure that your representatives are supporting those pieces of legislation. The community needs to kind of rise up and say that these are important pieces of the overall HIV/AIDS portfolio as they're doing their work. One of the things that we've been really keen on is we want to make sure that we're talking about it being part of the larger solution to ending the epidemic. We were really pleased that at AIDS Watch, for instance, housing was really integrated into the overall ask, that it's part of the larger picture if we really want to end the epidemic.
Awesome, thank you for that response. We have 3 questions and 2 from Craig, and then 1 from Lee. So I'll start with Craig's questions. So he asks, once people living with HIV are adequately housed and in a stable environment, how do we maintain them in that stable housing while dealing with underlying issues such as substance abuse, physical abuse, and mental health issues?
So this is where supportive housing is key. So one of the things we are strong proponents of is making sure that there are wraparound services that are attached to the housing but not contingent on the housing. We want to be real clear that people are not in housing, that their housing is not based on whether or not they attend treatment. We want them to be housing. We are very strong proponents of housing first. If you house someone first, then they're able to address some of the other concerns that they have in their life. So if the housing that the person obtains is not attached to these wraparound services, we need to make sure they have a strong case management connection so that the case manager can connect them with the services that they need, that there are periodic checks to make sure that they're maintained in those services, especially when you're looking at issues such as substance use and domestic violence. the periodic checks are going to be key to sustainability in those services, because there is so much stigma attached to those, especially, and so much shame when there is a relapse. And that's a part of the care and treatment of people, especially in those parts of our community. So we need to make sure that we have the strong case management that has the connection to the wraparound services, systems in place where there are periodic checks to make sure that people are maintaining their health, as well as their services as they are needed.
Perfect. Thank you. And so the next question from Craig is, how do we get landlords and realtors back on board to provide suitable housing in light of the fact that they have been disappointed repeatedly? For example, non-payment of rent due to drug use or abuse.
So that's a harder question. The best way to be able to keep landlords engaged is success, and that's really putting pressure on our funding, our grantees, to be able to make sure that they're paying on time. One of the things that has been the biggest challenge, and why landlords are less likely to want to work with our community, is that they're competing with non-programmatic housing. So people who are working or are not disabled or not in need of assistance, being able to pay rents without assistance. And our grantees, not just in the HIV/AIDS service arena, but our public funders of Section 8, of many of the disability funding sources, have been really slow or late in payment, which has made it really challenging for our community to really maximize those services, because if given the choice, landlords are going to choose someone who is not in a program as opposed to one that is. Where we have seen successes, and we would love to hear more stories of this, is when there has been a concerted effort by the grantee to develop relationships with the landlords on an ongoing basis. It's really important that those who are delivering the funds and the landlords that are receiving the funds are in really strong relationships. And there are communities that have done this very well, and that we've seen landlords come around. It's a slow process, and I wish I could say that there was an easy answer to it. But if you are in a community where the funds are being released slowly or inconsistently, a lot of it is working with your funding source, be it your grantee, whoever, and really talk to them and advocate for them to get on a timely payment scale, as well as to develop strong relationships with your local landlords. But it really needs to happen at that level. Very rarely is it the case that it's the individual in the apartment that needs to kind of change the relationship. It's really about the grantee or the payor developing the relationship with the grantee.
Thanks, Christine. So we have one more question regarding the National AIDS Housing Coalition. And so Lee's asking, does the National AIDS Housing Coalition offer capacity building assistance for those wanting to expand their services to include a HOPWA program? And if so, how do you access those services, capacity building services?
The National AIDS Housing Coalition kind of serves as a connector. We have strong relationships with all of the TA providers, both in Ryan White as well as HOPWA, for the HOPWA programs, that we can, if your community would like to have technical assistance, you can call us and we can connect you with a TA provider in your community. If you go to the next slide, my contact information is there, and we can make sure that that happens.
Perfect. So for anybody who's on the call who's interested in adding housing programs to their existing services, you can reach out to Christine at the email that you see on the screen now, and she'll be able to connect you to folks who offer capacity building and technical assistance. So if we don't have any more questions, I'd just like to reiterate a huge thank you to Christine. This presentation was actually extremely enlightening for me, and I'm sure for the participants as well. And so for folks who are on the call now, I will be sending out an email later on today with the slides and with a recording of the presentation, just in case you want to share it with some of your colleagues. And so with that, I hope that you all enjoy the rest of your day. And again, thank you so much, Christine, for your time.
My pleasure. Anytime.